Hi, today I will be talking on some of the other aspects of pharmacokinetics. Now coming to biotransformation or metabolism, this is required to convert the non-polar drug into a polar substance. This facilitates the elimination of drug from the body. So metabolism is a very essential process for drug elimination or the disposal of the drug. The main site of metabolism is liver. The other sites involved in drug metabolism are gut, kidneys, lungs, and brain. The metabolism requires or it involves two phases, phase 1 and phase 2. The phase 1 metabolism is oxidation, reduction, hydrolysis, and cytochrome activities, whereas phase 2 metabolism is a conjugation process. Now, the phase 2 metabolism may involve conjugation of drug directly with substance like glucuronic acid, sulfuric acid, acetic acid, etc., or it could be conjugation of phase 1 product with these substances. But eventually, the metabolism convert the non-polar substance into a polar substance for elimination. Now, cytochrome P450 has a very specific enzyme in the liver, which is a heme protein. There are three main types: cytochrome P1, cytochrome P2, and cytochrome P3. These three are majorly involved in the metabolism of the drug and other substances. These cytochromes, they differ in amino acid sequence, their sensitivity and specificity for inhibition and induction. There are inter-individual variation, means that two different individuals have a different cytochrome pattern, may have. The genetic polymorphism and environmental factors, the dietary factors, and herbal and OTC products, all these can influence the cytochrome P450. Now, there are certain drugs which causes induction of cytochrome. They stimulate the enzyme cytochrome P450, leading to a drug interaction. So what kind of drug interaction? Let us see what are the enzyme inducers. They are carbamazepine, barbiturates, phenytoin, and rifampicin. There are so many others. Now, these enzyme inducers, if they are used with any other drug, there is a potential interaction of causing lesser therapeutic effect. Say, for example, rifampicin used with oral contraceptive. Because rifampicin will expedite the metabolism of contraceptive or oral contraceptive, so the concentration achieved would be less, leading to failure of contraception. Similarly, there are certain drugs which cause inhibition of cytochrome enzyme. These are like fluconazole, cimetidine, erythromycin, isoniazid, cyclosporin, amiodarone, etc. Now, these drugs, if they are used with other drugs, they may lead to accumulation or toxicity of the drug, which is used concomitantly, and may lead to some side effects. Take the example of fluconazole with warfarin. If both these two drugs are given together, the fluconazole will inhibit the metabolism of warfarin, leading to accumulation and so the bleeding problem or excessive bleeding. Similarly, erythromycin used with simvastatin, which is a hypolipidemic drug. So erythromycin will tend to accumulate simvastatin by inhibiting its metabolism, causing rhabdomyolysis or muscular problem with simvastatin. In one case or some few cases, there could be an enzyme inhibition which is beneficial. Take the example of ritonavir, which is an anti-HIV drug. It inhibits the enzyme cytochrome P3A4, and if it is given in combination with another anti-HIV drug, lopinavir, it increases the concentration of this drug lopinavir and causing a better therapeutic effect. So sometimes these drug interactions by inhibition of enzyme or by induction of enzyme could be beneficial, but they are very few. The other aspect is excretion, which is primarily taking the drug out of the body. Kidney is the most important organ for excretion. About 30% of drugs used in humans are excreted unchanged by the kidney. Means they are not metabolized. They are just excreted directly by the kidney, which is a significant percentage. The other routes of excretion are bile, feces, and lungs. Say volatile anesthetics, primarily gaseous anesthetics, they are eliminated by lungs. Some minor route of excretion are saliva, sweat, tears, and breast milk. Now, breast milk is more acidic than plasma. So, it will eliminate basic drug more because the basic drug will be more in the polar form. Some of the drugs like alcohol and urea, they can enter into the breast milk easily and they can accumulate in plasma, and in fact the concentration in breast milk of these substances are almost equal to that of plasma irrespective of the pH. Hair and skin also make some contribution for certain substances, but their significance is only for mostly forensic or medical legal purpose. The clearance is another single most important factor which determines the drug concentration. The clearance depends on the dose of the drug, depends on the organ flow, it depends on the intrinsic function of liver and kidney. Because in the clearance, the hepatic clearance and the renal clearance both are important. Clearance is important in designing the rational dosage regimen. This is how it is decided that at what frequency the dosage should be used, at what interval, and how much dosage should be given. So that depends on the clearance of drug from the body. Clearance is the rate of elimination of drug by all routes normalized to concentration in some biological fluid where measurement is made. And it is essentially depends on the rate of elimination and concentration. So clearance is directly proportional to the rate of elimination and inversely proportional to the plasma concentration. The another important point about a drug is its half-life, and it is the time taken for the drug in plasma to become 50%. It is time taken for drug plasma concentration to half is half-life. It is not a direct measurement of drug elimination. Plasma half-life is decided by volume of distribution as well as clearance of the drug. So if you see the equation of half-life, it is a constant of 6.693 multiplied by volume of distribution divided by clearance. So half-life is directly proportional to the volume of distribution and inversely proportional to the clearance. And half-life is useful in designing the dosage regime, at what frequency it should be given. By and large, the half-life helps in deciding the frequency of administration. It also determines the time to achieve the steady state concentration. Steady state concentration depends on the half-life. Shorter the half-life, quicker is the steady state. If it is a long half-life, it takes longer time to achieve the steady state concentration. The another important thing which is important from the practical point of view is called bioequivalence. The bioequivalence is comparing two drugs. One is a test substance, another is a reference substance. And this study is conducted in healthy subjects, and for the drugs which are immediate release formulation, they are conducted single dose study under fast condition and under fed conditions. And after giving a single dose of reference and test drug in a crossover fashion, there are same individual, the same volunteers receive both test and reference at two different times. And eventually, Their concentration is measured in plasma. Their Cmax, which is the peak concentration, AUC, that is area under the curve, of both reference and test drug is calculated. It is log transformed, and the ratio, if it falls between 80% to 125% with 90% confidence interval, we call it as a bioequivalence drug. Means if the two drugs are bioequivalent, means they will have same safety and efficacy. So single dose study of bioequivalence with under fast and fed condition is applicable for immediate release formulation. Of course, there are exceptions where only for immediate release formulation there is only fast study, which is enough. There is no need of doing the fed study for immediate release formulation. The Cmax is the peak concentration of drug in blood, and Cmax denotes the rate of absorption. If you compare the Cmax with the time to achieve the Cmax, which is called Tmax, so this defines that how fast the drug is absorbed, and usually it defines the onset of action. The area under the curve, AUC, it depicts the extent of absorption. The total absorption of drug is depicted or shown by area under the curve. And for bioequivalence, both Cmax and AUC are the main ratio, are the main parameters which are looked for comparison. For sustained release formulation or extended release formulation, usually the bioequivalence is calculated on the basis of multiple dosing. The multiple dosing has got slightly different parameter. In multiple dosing, if you see in this picture, there is a 0.1, 2, 3, 4, 5, 6. These indicate the number of half-lives. So if you see that after the first administration at 0 point, the drug concentration goes up, then the first half-life is coming down, the dose is given again, it goes up, then the second half-life comes down again, then again the drug is given, it goes further, and so second, third, fourth, etc. and fifth, it continues. But initially what we see, there is a rise in the Cmax, but after 3 or 4 half-lives, usually there is no change, and the rate of absorption and the rate of increase and the rate of decrease is almost the same, which indicates that absorption and elimination is almost the same. When this state is achieved, this is known as steady state concentration or steady state levels. Now this steady state is achieved after 3 to 4 half-lives, precisely it is 4 half-lives. And this time to achieve the steady state depends on the half-life. It does not depend on the doses of the drug. So if you increase the dose of a drug, it does not mean that you will achieve the steady state faster. It will still depend on the number of half-lives. So if a drug has got a half-life of 2 hours, usually 2 into 4, that the drug will achieve steady state in approximately 8 hours time. But if the half-life of a drug is say 24 hours, the steady state level will be achieved in almost 4 days time. So it is irrespective of the concentration. The steady state depends on the number, it depends on the half-life, and so it decides. Steady state is important for achieving the therapeutic effect, number 1. Number 2, for extended release formulation or sustained release formulation, they are compared, steady state level is compared for reference and test drug, and they should be falling between 80-125 ratio for considering them as bioequivalent. And this steady state is important for deciding the therapeutic level or therapeutic effect as well. Thank you.